Assalamu alaikum rahmatullah. Good evening. My name is Isam Osman. I'm a consultant vascular surgeon and chair of vascular surgery at King Saud Medical City in Riyadh. I'm also the director of the operating rooms at King Saud. I'd like to start by thanking the Sudan Doctors Union for giving me this very kind invitation to speak to you all this evening. I'd like to extend my warmest greetings to my friends, many of them, my teachers in the Sudan. The SDU is an organization that is very close and dear to my heart. As a medical student, many of its senior members were my teachers and played an important part in instilling some of the professionalism that was important for a medical student to see. I'd also like to extend my warmest greetings to all my friends in the United Kingdom, especially my old friends at Ipswich Hospital and my many friends in the United States and other parts of the world. I've been asked to speak to you tonight about patient safety, quality improvement. These things happen. I'd like to start by making a confession, really. I'm not an expert in patient safety and quality improvement. I'm a surgeon, a vascular surgeon, and I started a journey in learning and understanding more about patient safety and quality improvement from many others who are far more qualified, some very bright people who've done a lot of work in trying to understand the factors that underpin patient safety and quality improvement. So I'd like to thank them also for giving me the opportunity to understand more about this really important subject. I've been asked to talk for an hour, but I think that's quite a long time, so I'll hopefully try to make it less than an hour. I'd like to just make an apology to all my Arabic-speaking friends and a confession that I still haven't learned to read and write Arabic, so if you have any questions, I'd be grateful if you could write them in English. I'm going to start off by just giving you what I understand the definition of patient safety to be. And then we'll talk a little bit about how I got into the journey of patient safety, and then go more into the talk. There are many definitions, but for me, patient safety is the systematic efforts that healthcare organizations make to try to eradicate avoidable harm to our patients. We admit patients into hospitals with many diagnoses. We try to make the correct diagnosis, and we try to cure them or treat them as best we can. Sometimes that treatment is followed by complications or occurrences and adverse outcomes or bad outcomes that even the best medical teams can do nothing about. That's not what I'm referring to when I'm talking to you about patient safety. What I'm talking to you about is the harm that patients come to when they're under our care that has nothing to do with the condition that brought them to hospital. Let me give you some examples. An elderly patient is admitted into hospital with a urinary tract infection, a waterworks infection for the non-medical watchers. And that elderly person is quite frail, and in the middle of the night, because of the urinary tract infection, they need to get up and walk to the toilet quickly, but they fall over and break their hip. That is harm that's come to the patient under our care. Pressure ulcers, patients who get pressure ulcers from being in bed and being immobile for a long time. Patients who develop sepsis after catheters and central lines that we've inserted into them as part of their treatment. Many patients, as you know, develop hospital-acquired pneumonias. Some patients, more rare, have surgery to the wrong side of the body, the wrong limb. And even worse, we occasionally leave things in the operation in the patient, such as swabs and things. The list is long, and you're, I'm sure, very familiar with them. This is a big problem. I'm not sure that people understand in healthcare how big a problem it is. In the United States, it's estimated that it's the third commonest cause of death after cancer and after ischemic heart disease. Something like 100,000 patients die in American hospitals every year as a consequence of medical errors that lead to avoidable harm. It's something that is quite a significant problem for the whole world. It's estimated that about 1 million people a year all over the world come to harm. Part of the problem is we don't have exact figures because it's not something that we are reporting openly, and it's very difficult and has been for the medical establishment to report the mistakes they make for fear of being blamed, for fear in some countries of even criminal litigation. So the problem is quite a significant problem. But you'll agree with me that as doctors and intellectuals, we cannot accept any form of avoidable harm in this circumstance. Those of you who have been unfortunate enough to have loved ones in hospitals and developed any of these will understand that your loved one went in with one problem and developed another completely unrelated problem. So I'll talk a bit about my journey in patient safety. I've practiced as a surgeon in the NHS for 25 years, the last 20 of which was as a consultant. In the early 2000s, on a holiday, I paid a visit to my sister in the United States. And as we were sitting there with my brother-in-law, engineer Osman Malik. Osman is a trained mechanical engineer and then went on to do higher studies in industrial engineering. Those of you who know Osman will agree with me that Osman is a polymath, in that his interests are extensive outside his field of engineering. He has a keen interest in sociology, politics, music, the arts, and indeed healthcare. We started talking, and Osman being a keen observer of the NHS, about what the challenges were in the NHS at that time. I was a consultant surgeon. I think I was chair of surgery at that time, and life was pretty good. So we got into a discussion about the challenges of the NHS. And pretty soon Osman was breaking down a lot of the processes that our patients were going through and finding big gaps in them. Understandably, I wasn't particularly pleased by all this, and we got into a heated discussion, and out came the flip chart. And before you know it, he was taking me through something called value stream mapping. It was the first time I'd come across value stream mapping, and we were looking at constraint points and looking at the thing that controls the takt time and all these engineering process management tools that, as a surgeon, I had never heard of. So we went to bed, and I have to say I wasn't particularly comfortable at the conversation. And the next morning he came round and gave me this CD-ROM and said, here, you might be interested in this. At that time I think he was doing a master's degree or an MBA, and as part of the MBA course he'd been given, the Harvard Business School Review had a case study of the Beth Israel Deaconess Medical Complex in Boston, a Harvard-affiliated hospital, that was going through a very difficult time and was on the verge of being sold to the private sector because it was a failing organization. A gentleman by the name of Paul Levy went to become the CEO of that organization, and the Harvard Business School followed him for 6 months in what was an exceptional transformation of that organization. That's become a case study that is taught in many MBA courses. It was one of the most formative pieces of learning that I've had as a postgraduate, and it whet my appetite to learn more about quality improvement and patient safety. So when I got back on a long shot, I sent an email to this man I'd never met before and said, I've seen your CD-ROM and it's really inspirational. If you're ever in the United Kingdom, do you think you would be good enough to give us a lecture on patient safety? I was very surprised when he replied very quickly and said, yeah, I'd be very happy to do that. In fact, I'll give you 1 whole week. I replied, Mr. Levy, we are an NHS organization, and you'll understand that our funds are limited, so I'm not sure that we can meet your honorarium for a whole week. He replied back, to my surprise, and said, no, I'm not asking for an honorarium. It's a good opportunity to come and share experiences and learn about some of the challenges you have in the NHS. And so it was. Paul Levy came to the Ipswich Hospital and spent a week in which we had workshops on quality improvement, patient safety, lean processes for those who are interested in some of the tools of quality improvement, strategic negotiation, and so on and so forth. And that was the beginning of my journey and interest in trying to make a difference in improving patient safety and quality improvement. So what do I mean by quality improvement? There are many definitions when you go online. The one that I like particularly is that it's a formal approach by health organizations to analyze their performance regularly and to have systematic efforts to improve it. And within that, central to that improvement must be the improvement of patient safety. There are many other modalities of quality improvement for organizations not involving patient safety, but patient safety is at the heart of all this. So, I'm going to talk to you about what I consider to be the 5 key drivers for patient safety. These are things that I've learned from a number of people in the subsequent years. I'd like to talk to you first about reducing unwarranted clinical variation and the impact it has on patient safety. Talking a little bit about understanding the types of cognitive errors, the mistakes that are happening within the health system. And that'll take us a little bit into human factors, which is an exciting new area where people are trying to understand the impact of human fallibility and behavior and mitigating the risk of that within complex systems. The aviation industry is an example where they've done a lot of work on that and from which we can learn. Thirdly, I'd like to talk about teamwork and its importance in the delivery of high-quality modern healthcare. What makes a good team, what makes a dysfunctional team, and some of the other issues around team-based care. Fourthly, I'd like to speak about just culture within an organization, the so-called blameless culture, and its importance in helping an organization learn from its mistakes. The term learning organization is an organization that is driving itself to change and improve from within and is not waiting for external factors to make it improve. And lastly, I'd like to talk about the role of transparency as a key driver in quality improvement. I'll talk about the first 3 first. I'll give you some examples and I'll tell you some stories. And then I think we'll stop for a little while. If you have any questions during that time, I'll try to answer some of those. And then we can carry on and finish the 2. So, reducing variation. Variation in healthcare is abundant. We treat patients with certain conditions in a number of different ways, and we do things to patients in a number of different ways. This variation not only leads to an environment where mistakes are more common, but for those health executives interested in cost effectiveness, it makes it much more inefficient, reduces productivity, and it makes it less cost effective. So why don't we do things similarly? Well, humans like to do things their own way. And those of you who've worked with consultants very closely, you'll find that they're very strong-minded people, and they've been trained to become that way, and therefore it poses a lot of problems. So let me give you the example of patient harm that comes from a lot of variation. Let's take surgical site infections, so wound infections after surgery. This is a major problem and causes a lot of morbidity and causes a lot of suffering for patients and in some cases even death. But to a large extent, by working in a similar way, we can reduce that. How do you do that? Well, as an organization, choose a priority area where you feel you have a lot of problems. in this case, let's say the surgical site infections. Get your clinicians to create an evidence-based protocol. So our doctors are very able people, and we're now in the world of evidence-based medicine. So find out what is the evidence for the things that we do to reduce surgical site infections. Once you've agreed a consensus on that, then you need to build some guidelines and embed those guidelines into a care pathway. Surgical site infection, or SSI as it's known, has a number of care bundles that are evidence-based and easily available. And it's about agreeing that that's what we want to do. And I won't go into the details of the bundles, but I'm sure you're familiar with them. And if you're not, you can find them very easily on websites such as the Institute of Health Improvement, NICE, etc., etc. Once you've got them in, then you need to monitor compliance and try to understand where the variation is happening and see why there's variation. Sometimes there are very good reasons for it, but more often than not you'll find there aren't. And it's been shown, repeated over and over again, if you apply these evidence-based pathways and bundles to patient processes, and you reduce variation, and you standardize process, you improve outcome, you reduce avoidable harm, and as a result of that, finally, you will actually deliver more cost-effective healthcare. So that is a key component, and alongside that, for those who are interested in productivity and process management, another pillar is the reduction of waste. But if you develop these pathways that are based on evidence-based steps, you'll also be doing that as well. That's probably the subject of another discussion, the ways of reducing waste within organizations and the tools that are available to do that. So let's talk about the types of mistakes that we see in complex organizations such as hospitals. I think the commonest error that you will see, and we've all been guilty of this, myself included, is what we call diagnostic anchoring, where you have reached very quickly, after assimilating an amount of information as a clinician, a diagnosis. And then you engage in something known as confirmation bias. So you only use the pieces of evidence in front of you that support your diagnosis. And you tend to ignore the pieces of evidence that are against your diagnosis. And in doing so, you go down a path which in the end turns out to be incorrect, and you've made a misdiagnosis. I remember many, many years ago, in 1991, when I first arrived in the United Kingdom, my first job was a locum senior house officer in Torbay Hospital. It was the summer of 91. Those of you who've been to Torquay, you'll know that it's a wonderful part of the country. Thank you, Amin, for that message. Let's have a look. Is that better? Yeah. And I was a locum SHO in general surgery. I was very excited to be there. I arrived from the Sudan, and I thought, this was a great place to be. There was a patient referred, a 73-year-old patient with left loin pain extending into the left flank, and I think he had some hematuria. The GP in his referral letter wrote, I think this is probably renal colic, but I can't exclude a leaking aortic aneurysm. I had never seen a leaking aortic aneurysm up until that point. I think the irony is I went on after that to become a vascular surgeon, and since I've seen very many. But that was the first time I saw a patient with a suspected leaking aneurysm. So I went to see him, and the patient had left loin pain. He was hemodynamically stable. His blood pressure was fine. He did indeed have blood in his urine. His hemoglobin was okay. So I thought, well, this GP doesn't really know what he's talking about. I call that professional arrogance. And so I gave him some painkillers and requested a KUB, which is an X-ray, to look for kidney stones, and went on seeing other patients. 2 hours later, I was very busy. I was on the ward, and I went to review the X-ray, and I put the X-ray up on the screen, And as I looked at it, I got this feeling of doom that went straight through me. Many a surgeon will be able to describe it. The best description I can give it is as if somebody took your head off and poured liquid nitrogen down your spinal cord. And I could see that one of the muscles, known as the psoas on the left, was missing, indicating internal hemorrhage. So in fact, this was a leaking aortic aneurysm. And just at that moment, the crash team were called. A patient had a cardiac arrest. The nurses jumped to it. And I sat there thinking, oh my God, what have I done? So I rang the senior registrar, and he came in. We rushed into the operating room, but sadly, that patient didn't survive. So, notwithstanding, I was absolutely gutted. I was destroyed. And I thought, well, that's the end of my very short career in the United Kingdom. The next day, the consultant came, and I told him what happened, and he said, well, you've learnt your lesson, but don't worry, Isam, these things happen. And life went on. What surprised me is that this is a scenario that I've seen over and over and over again, and goes on every day in hospitals all over the world. I suspect in the UK it's still going on now, and I've certainly, as a consultant vascular surgeon, seen it many times. And that is patients mistaking, doctors and staff mistaking renal colic in the elderly, or mistaking an aneurysm for renal colic in the elderly. So I asked myself, you know, if humans are going to make this mistake, and I've made this mistake, what's the system? And I believe that 95% of medical errors are not attributable directly to an individual. They're usually a series of small errors, and in that they are process errors. The system is not protecting itself from human error. So could we come up with a system whereby we would expect all patients in that category to be diagnosed correctly, so to reduce this sort of error? And indeed, latterly, in the UK, in Ipswich, before I left, I was pleased to be able to put in a protocol, and that's what we did. We went back, we tried to reduce the variation, we looked at the evidence, and we put in a policy where all men, because it's much more common in men than it is in women, who attend the emergency department with either loin pain, abdominal pain, over a certain age, over 50, especially with a history of smoking, should have an ultrasound scan within 30 minutes of arrival. And by introducing that, we've mitigated that. So, you know, that's an example of diagnostic anchoring and confirmation bias. I went down the route of confirmation bias, and I didn't give myself a chance, even though I was prompted by the letter from the GP to consider another alternative. So going on to errors, there are basically three types of errors, and I've heard Paul Levy speak about this recently quite a lot. There are errors based on knowledge-based errors, and these occur when the wrong step is taken due to a lack of knowledge. These are less and less within healthcare, and they tend to involve the more junior members of staff, particularly when they are left unsupervised, where they don't have the senior supervision. The second type is rule-based errors, where people misapply existing rules or guidance. A great example of this is the concern that people have with impaired kidney function, CKD, chronic kidney disease, and the use of iodine-based contrast to do things like CT. You know, you do need to be careful when you use contrast when you do a CT, but it depends on how bad the kidney function is. And if you are in an emergency situation and you have a patient who's really ill and you need a diagnostic CT to help make important decisions about the care of that patient, then you should go ahead with the CT. And I've seen it over and over again, especially more recently, where people are withholding contrast CTs because the patient's kidney function is slightly abnormal, where actually the rule doesn't say that. The rule says do the CT in an emergency situation unless their kidney function is so bad, i.e. CKD 4 or 5. The more common errors, however, are what we call the skill-based errors, where people take the wrong step when doing something through a lapse, through just a moment of, of not thinking. And these tend to involve the things that we do day in, day out, over and over again. And these are by far the vast majority of the mistakes and medical errors that we make in healthcare. So what do we need? We need systems that protect patients from these types of errors, and we need to introduce things like checklists. We need to standardize processes. We need to give pathways for people to try to reduce those types of mistakes. So this is a slight sort of introduction into the types of mistakes and errors that people make. The third type of important, let me have a look here. Got my papers in a muddle. Yeah, the third is let's talk about teams and the importance of teams in the delivery of modern healthcare. Those of you who've worked in complex medical specialities, certainly in the Western world, will understand that modern care has to be delivered by multidisciplinary teams. And as a surgeon, the team is not just me and my registrar and my junior doctors. The team involves the anaesthetist, it involves the physiotherapist, it involves the nurses, it involves the occupational therapists, intensive care, depending on the disease condition. And we are moving now from what we call these vertical silos of surgery, anesthetics, to develop organizational pathways that encompass all the specialities that deal with that type of patient. And there are qualities that make teams very successful. These are teams where they have a shared common goal. There's a clear structure to the team. Everybody has a role and understands their role. The team is flexible. The team shows resilience, and so on and so forth. The example of a team not working well, I'll give you a really interesting example. Was many years ago in I think it was the mid-90s, there was a South Korean jumbo jet that flew into Stansted. It was a cargo plane. And this plane flew across from Seoul, landed in Stansted, and on the way there was a technical problem with what we call the altimeter. The altimeter is the artificial horizon. It tells you where the airplane is in relation to the horizon. And there's one, I believe, in the captain's seat and one in the co-pilot seats. And the one in the captain's seat wasn't working. The team that flew the plane then knew it wasn't working. So when they landed in Stansted, they reported it to the maintenance department and said, this altimeter's not working. I think maintenance thought they'd fixed it or forgot to fix it, but actually it was never fixed. As the plane came to return a few days later, the pilot who flew it there had to stay in London for one or two things. There was in the UK already one of the most senior pilots in South Korean Airlines who'd had tens of thousands of flying hours, and they said to him, look, can you fly this plane back? And he said, yeah, sure. So he flew back with the co-pilot who came on the airplane and the flight engineer who was on the airplane, not knowing that there had been a problem with this altimeter, this artificial horizon, and he took off from Stansted Airport in the middle of the night. The co-pilot knew that there had been a problem, and on his device he could see a difference between the pilot's device. And this pilot was overcorrecting on a device that was wrong. The plane crashed into the Essex countryside, killing the crew and killing a few people on the ground. And when they looked at the black box, although the co-pilot knew that this device wasn't working, he didn't say anything. He kept quiet. The flight engineer, towards the end, you could hear him shouting, bank, 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 meaning, the device isn't working. But the pilot ignored it, and the plane crashed. This was a disaster for Korean Airlines, and they, on hearing this, went back to look at the culture of their organization, and they introduced something called crew resource management, which is a way of training teams together to make them to mitigate for such a situation. And basically, crew resource management is if you think anybody's making a mistake, you call out the mistake and say, you're making a mistake. And if that person ignores you, then you reach out and you touch them on the shoulder or above. That tends to get their attention, say you're making a mistake. And if they still ignore you, you take action to prevent that mistake, even if that person is your senior. And that is something that's developed from the military. And you will not be punished for that. Now, I have seen that over and over again in healthcare, where a senior member of staff, a consultant, does something which makes a mistake, and then other members of the team will say, yeah, well, I mean, I thought that was going to happen, but they didn't speak up. They didn't talk about it. If you have the time, please Google something called it's on YouTube, called Just Another Routine Operation. It's a video about the sad death of a lady called Elaine Bromley, who had very routine sinus surgery. And when they were intubating her, they had a problem with her airway. What anaesthetists will understand is can't intubate, can't ventilate. And the consultant anaesthetist got another 2 or 3 consultant anaesthetists. The action to be taken in that situation is a tracheostomy. And the nurse, seeing this going on, went and brought a tracheostomy set to the surgeon and the anaesthetist, but they completely ignored her. They just sort of carried on trying to intubate this lady who couldn't be intubated. And this is what you call a problem of situational awareness. So teams are important, and every member of the team is important, and every member of the team needs to feel that they are empowered to speak up when they see a mistake. If you do that, you'll find that you'll make fewer mistakes. And for the senior surgeons, it's a difficult thing for some of the old senior surgeons, the quite experienced people, but they have to train themselves to empower their staff to be able to speak up and to recognize that although they are experienced and senior, they can make mistakes. The amount of, if the healthcare system was the aviation industry and the incidence of errors we're making, that would equate to 2 jumbo jets crashing every day. Crashing every day, dying, killing everybody in it. Now, we would never accept that in the aviation industry, so why do we accept it in the health industry? That's a really important question. And people who say, well, this zero tolerance is not possible, my answer to that is, intellectually, you cannot defend a situation where you accept you are going to harm people by errors that have nothing to do with the condition that they're in. It's very important that we take a zero tolerance approach and try to do what we can. Now, what are the things that make teams dysfunctional? Well, there's a gentleman who's written a really good book, if you want to read it, called The 5 Dysfunctions of a Team, Patrick Lencioni, that's Lencioni, and he talks of a pyramid of the things that happen within teams that make them dysfunctional. At the base of the pyramid is an absence of trust. The team members don't trust each other, and they don't trust each other in being prepared to share and show their vulnerabilities. As a leader, if you're ever leading a team, it's really important that you are prepared to show your team members that you are vulnerable as well, and to be open about your vulnerabilities. That engenders trust. Once you trust each other, then it allows you to do the next most important thing, which is to be able to challenge each other. And the fear of challenge or fear of conflict paralyzes the team. We've seen it many a time where you think something's not right. Well, in fact, you know it's not right, but you know what? You don't want to get into an argument with the person on the team because it's just not worth it. And that is a symbol of the fact that you do not trust each other. if you don't trust each other and you're not prepared to challenge, then that will lead to a lack of commitment. And you say, oh well, you just go and do your job and go home, and it's not really something you want to lose too much sleep over. And then more and more people become less committed, and when you become less committed, you try to avoid accountability. And well, it wasn't me, it was him, and you see that a lot, especially in the cultures, the Eastern cultures, more so than you do in the Western cultures. I don't know, maybe that's just an observation. I don't know the reasons for it, but once you've lost accountability, then people stop paying attention to the results of the team. So these are the 5 common reasons: the absence of trust, the lack of trust leading to fear of conflict or fear of challenge. Conflict is healthy, challenge is healthy, and good teams challenge themselves and team members challenge each other frequently. That then leads to a lack of commitment from certain team members, and everybody starts to avoid taking accountability and apportioning blame, and eventually things deteriorate. Lastly, in this area, I think the really important message is, and more so, especially in the developing part of the world and the emerging healthcare systems, is multidisciplinary team care, especially for complex diseases such as cancer, vascular surgery, cardiology, chronic obstructive airway disease, bringing together a number of specialists and nursing and enhanced nursing roles to meet the patient's needs, where everybody is bringing an expertise that the other doesn't have. That is an essential process of developing and reducing avoidance of harm and improving patient safety. So we've gone through the 3. I know Hisham wanted me to just stop for a little bit at this stage to take any questions, if you want to pose any questions. So if you want to put them on the screen, I'll try to answer them, and then we'll go on to the final 2 parts of the talk. Any questions? Some old friends from the US, Mohammed Akkad, Taysir, Ahmed al-Wahabi. So I'm not getting any questions, so I'm assuming that you're all stunned into silence. Okay, well maybe you can think of them and I can answer them at the end. Yeah? So I'll carry on if I may. Right. The 4th category, and this is probably the most difficult, I think, is this just culture. Trying to, if you accept that humans are fallible and they're going to make mistakes, and if you want to be a learning organization to understand how these human fallibilities interact with your processes, you need to create an environment in which people are not blamed for their mistakes. Mohammed Akkad, let's have a look. What are your thoughts on over-regulations resulting in physicians being reluctant to take care of high-risk patients or situations to avoid being cited for them? That's a really good question, Mohammed, and certainly in the UK, following the Bristol inquiry, where we had a lot of babies die due to bad surgery, the cardiac surgeons and now even vascular surgeons and most surgeons are having their results published. And as a result of that, people are becoming frightened of taking on the high-risk case. The answer to that is I don't believe that there's any merit in publishing the results of a single surgeon. The reason for that is, in order to show a statistical variation, to show that somebody's an outlier, the sample size of operations that person has to do would probably take years and years, 5-10 years at the least. And therefore, actually, it's meaningless, because as we've seen in the Vascular Society in the UK, all the surgeons, and you can Google these are available now, all the surgeons are within the expected statistical distribution, whether you have 0% mortality over 2 years or have 15% mortality. There just aren't enough cases in each group. And therefore, I think, and also it goes against this team-based care. If you accept that modern healthcare is best delivered through complex teams, why are you just naming a single person, a surgeon? I think the way to do that is to publish hospital results, and over a period of time that you can demonstrate after risk adjustment, and that's really key, because some patients are higher risk than other patients, and you need to have robust tools to be able to differentiate between risk. Once you do that, then I think, certainly for me, that offers the protection to take on the difficult case, the case that has got a higher mortality. Another way of dealing with this is, I think, and we've started to do this, is to have two surgeons operating together. And in doing so, the two of them not only provide consultant input at two consultant input, but they also provide cover and support for each other. In particular, this fear of being cited for a case. It's much harder to make a case against two surgeons than it is for one surgeon. So those are my thoughts on that particularly, and I hope that's answered some of your questions. Right, and going back to this blame-free culture, it is actually very difficult. Don Berwick, who my colleagues in America will know very well, spent some time in the NHS, and he said one of the most important things was about creating a blame-free culture. I'll come to your question, Taysir, in a little while about managing toxic doctors. Don Berwick acknowledged it was going to be difficult, but if we accept that humans are going to make mistakes, and we accept that the system has to protect against that, then you have to accept not apportioning blame. The truth is, the overwhelming majority of medical disasters are never due to one big mistake. They are due to a series of small mistakes that happen to line up in such a way, what we call the Swiss cheese phenomena, where you drop through all the holes that align at the same time. And in order for people to feel free to report these, they have to feel comfortable and safe to do it. I did an investigation of a case, which I'll share with you, and in a redacted form, where a spinal patient who was due to have an injection of a facet joint on the right side had it on the left side. And when we looked into it and did a root cause analysis, in fact I did what's known as an after-action review. I chaired an after-action review, which is a tool, a learning tool we've taken again from the military, which asks 4 questions essentially. You bring together all the people involved in the care and you ask, what did we expect to happen? What actually happened? Why was there a difference? And what can we learn from that? And when we got everybody together, it was a really interesting story. There were 2 lists running next to each other. One list was running behind and one list was running ahead. So the surgeon asked the list that was running ahead of schedule to say, could you do a few cases for me? And he said, yeah, sure, because we're going to finish early. And so that's the first variance. The patient who was on one surgeon's list was put onto a second list. Because these spinal cases, they do a lot of them, they can do 12, 13 of them, they tend to come in and there are no, there weren't beds for these 12, 13 patients, so they tend to come in and they're into a waiting area, admissions unit, and from the admissions unit they go into the operating suite. So this particular surgeon was consenting them in the anesthetic room and not allowing them to be marked in the admissions unit. He wanted to do the marking himself. But his patient went to the different operating list, where in fact the procedure was not done by a surgeon but by a nurse specialist. He understood it to be the left side. The patient then rolled on his tummy. The patient was awake under sedation. But what was really interesting is what I found is when we looked at the checklist, it was ticked that the site was marked. That's part of the WHO checklist. And the nurse that ticked it volunteered, said, yeah, I ticked it, although it wasn't done. This surgeon never ticks, never marks his patients. So that is what we call a normalization of the deviance. So although everybody knows it should be ticked, and it's not ticked, they mark it as ticked, because it's been happening for such a long time and nothing's happened. And this concept of normalization of the deviance has caused many a disaster. The NASA has fallen foul of it. If you look at the Challenger disaster, they knew before takeoff that there was a gasket on, I think, one of the engines that was faulty. But it had been faulty before on a number of flights, and it had been okay. So they normalized that deviance. What should have happened is they should have stopped the flight and fixed the gasket. It happened again 7 or 8 years later with the Columbia. They knew that the heat tiles on this spaceship were not all working properly, but they'd flown many a flight with faulty heat tiles, and it'd been okay. So they normalized the deviance. And what this nurse had done is that she had, she knew that everybody should be marked, but this surgeon didn't like to mark, so she ticked it as marked, because if she ticked it as not marked, the system would have said, so, why aren't you marking it? And it would have been a headache. So she normalized the deviance. I was very keen that nothing should happen to her, because that was a very useful piece of information, a learning point that allowed us to make changes to the process that protected patients in future. And that's what I mean by a blame-free culture, in that people feel free to report things honestly, and learning organizations will use them to get better and better. In the airline industry, pilots will report themselves. They will report themselves. They will say that this went wrong, and they will then be part of an investigation where they learn how to stop it from happening again. I have, on 1 or 2 occasions, filled a day text against myself to everybody's surprise, and said, we've never seen anybody fill a day text about themselves. I said, well, I had a problem in the operation which I hadn't foreseen, I hadn't prepared for, and luckily we got away with it. It's a near miss, and I'm sure there's learning there for me and for everybody else. And if I don't use the system, I won't be able to share the learning. So that is it's a very difficult thing to do. It's very difficult. I accept that, but it requires leadership from the top of the organization, chief executive levels. And this brings us to a point where, Jaysir, your question, that sometimes there are managers who don't understand this and are not going to support this sort of behavior. But the important thing about quality improvement is that it's not a big bang. You can't do it all at once. Sustainable quality improvement is incremental. It's little by bit. And although there may be some manager here or manager there who are very difficult to work with, if you don't make any progress with those managers, concentrate on the areas where you can make progress. And slowly, little by little, month after month, year after year, you look back and you'll find the organization is a much safer place than it was 2 or 3 years ago. So quality improvement is incremental. It's not necessarily something you will get done quickly. And this is one of the problems and I'm sure we've all seen this. Hospitals are struggling a little bit, so they bring in outside consultants. And we've seen them all, very able people. I'll mention their names so you know who I'm talking about. KPMG, Price Waterhouse, Ernst & Young, McKinsey, so on and so forth. And they come in and they work with you and they help you see what it is you probably already know, and they get you on your track and they go away. And it goes on for a little while and you flip back. The change is not sustainable. And it's not sustainable because you've not done it in an incremental, structured way that has taken people along with it, changed people's behaviors, changed organizational culture. That takes time, and it takes very good leadership. Right. I'm now going to come to the final bit, and I think this is the crucial bit, is transparency. DATEX. Oh, people are asking about DATEX. DATEX is a risk management system. In the kingdom here, in our hospital, we call it OVR, Observed Variance Report, where something happens that shouldn't have happened, and you log it in a system whereby it then gets investigated, and it allows the organization to manage its risk. So first of all, you might get a theme that something's happening repeatedly over and over again related to one particular risk. And then you realize that you have a risk in this particular ward or this particular operating room of a certain type. And then if the risk happens again, and there's a risk scoring system, so if the likelihood of this occurrence is high and the consequences of it are high, there's a system that gives the risk a score, and if it becomes very high, it then goes on to the risk register at a much higher level of the organization, and in some organizations, even at board level, executive board level. So it's a risk management system. So if something occurs which is a deviance, you encourage staff to report it. And the airline industry are the best at this. Anything that's out of the ordinary, they will report it. They've got a system, it will be investigated, and the organization will learn from it. Like I said, in the Middle East it's called OVR, Observed Variance Reporting. Right. So let me come back to the transparency. Now, transparency is a very powerful tool. It is the most important step for me, I believe, of quality improvement. And what you do, and if you go back to the definition of quality improvement, you need to have systems that allow you to measure accurately the things you want to measure. So in patient safety, we want to measure falls, we want to measure pressure ulcers, we want to measure line sepsis, we want to measure catheter-related sepsis, we want to measure venous thromboembolic events, and have this information available to us at hand. Once you have it, then you need to publish it, you need to share it. And you need to share it in great detail, even attributing it to teams, in some cases to consultants. And then you get to what we know as consultant dashboards and things. And that is very, very powerful. The first thing that will happen is you'll get a really significant backlash from medical staff and nursing staff and say, the data is wrong, the data is wrong, the data is wrong. And yes, in some cases the data is wrong, but there's no such thing as perfect data. We all live with some corrupt data at a certain level. You think there's 3-4% of this data is corrupt. But the answer to that is yes, okay, well, the data may be wrong, but work with us to help us make the data more accurate. And what you've observed is that once you start to publish this information and you're transparent about it, performance improves. Everybody's, and doctors, and nurses and everything, you say, oh, well, have you seen, Hisham al-Khidr's infection rates? Ha, ha, ha. And, they talk to each other, and immediately everybody lifts up their performance. It's something called the Hawthorne effect, and it's one of the human factors that people do. That data publication allows you to see the transparency, allows everybody to see how everybody's doing against these important patient safety indicators or KPIs, key performance indicators. It allows you to identify which areas you need to support, to improve. It allows you to focus your attention on processes in certain areas and say, okay, we seem to be having a problem in this speciality. What is happening here? It may be that the processes are wrong. It may be that the team is not working well. There are a number of things, but it gives you that information, and making it transparent is really important. If you accept, and I'll go back to the beginning, that we have a zero tolerance for patient harm, and the target is zero, when you publish and show that, well, we've had 180, and the Beth Israel have shown this very well, 180 cases of hospital-acquired pneumonia, the mortality of which is 30%, and you say it's zero, that area under the curve, that delta area under the curve shrinks You may not get to the zero, but you get a lot closer to it than you were originally. And that delta elasticity, when you look at it, you might find in 2 or 3 years you've reduced your hospital-acquired pneumonias from 180 down to 40. You've not reached zero, but you've probably saved about 40 or 50 lives per year. Now that's valuable. That's meaningful. Yeah, that is that nobody can argue against that. Yeah, and that's why it's important. Even though, and you need to set the standard, say we will not accept these, and this is where we are now, and we want to be at zero in a number of years. You set yourself a trajectory. Transparency is the key to quality improvement. And for my colleagues in the kingdom, if you look at the new Vision 2030 and you look at the transformation plan for healthcare, transparency is at the heart of it. And I believe, I'm not aware of anywhere else in the Middle East where there's been such a systematic approach to quality improvement through transparency. And believe me, it's very difficult. People don't like to have their results in the open. We went through it in the United Kingdom. Now my results as a vascular surgeon you can Google and find on the internet. I'm not sure that patients are able to make much sense of it, but the effect of it is that it tends to improve performance. It does improve performance. So those were the 5 key points that I believe underpin quality improvement and patient safety. I'll just summarize them again for those of you who weren't on at the beginning. The first is to reduce unwarranted clinical variation. Let's try to all do the same thing. We all do hernias. We all used to do hernias in different ways. We used to do Bassinis, we used to do nylon darns, we used to do laparoscopic, and then along came the mesh, and the evidence showed that using a mesh was better than a nylon darn. Then we developed pathways based on evidence, and now 90% of the hernias we're doing are being done with a mesh. And surprise, surprise, the recurrence rate for these hernia repairs dropped from 30% down to 1%. So let's reduce clinical variation. We talked about the types of cognitive errors, and in particular confirmation bias. We talked about diagnostic anchoring, and that is, I think, something we're all guilty of. All doctors and nurses are guilty of that. If you look at your own practice, you will see that. Teamwork and the importance of functional teams and what makes teams work well. We talked about that. We talked about the things that make teams dysfunctional: absence of trust, fear of conflict, a lack of commitment, avoidance of accountability, and inattention to results. We talked a little bit about crew resource management and how you can use that to improve team behavior. And we talked about trying to create a just culture, recognizing that humans will make mistakes, but recognizing that these mistakes occur within a system, and the system has to take that into account. It has to have checks and balances. If you're really interested more in this, I would suggest you read a bit more about aviation and how we can learn from aviation, but I'll just talk a little bit about the miracle on the Hudson. My American friends will know about the airliner that took off from LaGuardia, Captain Sullenberger, Sully. There's a movie that's come out recently, and soon after takeoff you lost both engines to a bird strike. If you study the cockpit conversation of what happened in those, I think, the 289 seconds, you will understand the importance of systems that help protect against human behavior. As soon as this happened, Sully and his co-pilot started an emergency checklist. So put yourself in that situation. You're taking off, the engines, both engines go, and basically the airplane's falling out of the sky. It's slightly different for doctors because the consequences of our mistakes and things, we don't normally die. But if this crashes, everybody dies. And as they were doing the checklist, one of the things they worked out is whether the glide they had would take them a certain distance. So when the tower came back to him and said, "We have a runway for you at LaGuardia, he said negative. When he said, we have a runway for you and whatever, he knew by doing the emergency checklist, which he's been trained to do, he could not make it that distance. So that left him no other option but to put it in the Hudson. Now, even then, he was in a very difficult position. But you cannot win the lottery unless you buy a ticket. As difficult as it is to win the lottery, your chance of winning it is zero if you don't buy a ticket. That checklist gave him the ticket. It bought him the ticket to land it in the Hudson. And due to his experience and skill, Captain Sullenberger was a Navy glider pilot, so he was, he had experience in gliding aircraft. He was able to land it in the Hudson, and everybody survived. Now, they say he's a hero. The checklist gave him a chance to be a hero. And that is what I mean about systems designed to assist humans and their behavior in certain situations. And lastly, we talked about transparency. And its importance. Hisham just asked me, if you adopt transparency, what about litigation? Well, the experience, certainly from the United States, and if you look at the Beth Israel and Paul Levy, they found that being more transparent reduced litigation, in that it is very difficult to litigate against a hospital that is open and trying to improve and wants to learn. So the idea is that actually there's no correlation about increased transparency and higher litigation. In fact, it's more likely to be less litigation. The issues that, interestingly, that are associated with higher litigation, Hisham, is bad communication. You see that in the complaints. If you don't communicate, if you are open with patients and say, we've made a mistake, and this is what we call our duty of candor, and that we want to learn from this, and we want to improve so it doesn't happen again, complaints go down and litigation goes down. There's no doubt about that. So transparency doesn't lead to higher litigation. There are other things that do, hiding mistakes, not being open, and not saying, look, I've made a mistake. I'll share with you, if you want, one of my own experiences. I had a lady who I remember very well. She was 65, very well, found to have an incidental splenic artery aneurysm, 4.5 centimeters. So it was quite a big splenic artery aneurysm. We had to do something about it. You should treat it if it's more than 2.5 centimeters. And we discussed her in our MDT. We had a full MDT discussion about the treatment options. It was quite a long way down the splenic artery, so one of the options was to do a splenectomy. The other option was to do a radiological procedure and to coil it. The MDT made a mistake in that we didn't really have the quality of imaging to inform a decision like that, but we decided to do it. And we coiled this aneurysm. We weren't able to, without getting too technical, to coil the entry and the exit. We only were able to coil the entry and the aneurysm. So the exit was still open, and the back pressure filled this aneurysm, and she ruptured the splenic artery aneurysm in the middle of the night. Unfortunately, due to diagnostic anchoring, delay in diagnosis, when she made it to the operating room, she died. And that was very difficult for everybody. But myself and my interventional radiology colleague, we sat with her husband, and we had given her a very informed consent. She knew the risks associated. She knew this was likely, this was one of the possibilities. She knew the options, and we were very open and said, we've made a terrible mistake. In hindsight, we should have gone for the surgical option. And he was very understanding and said she knew the risks involved, and she made an informed decision, and you did your best. And that's the point. Everybody, these mistakes are not happening because people are not caring, or because they're bad people, or because they're not well trained. Healthcare workers are very committed. They're amongst the most dedicated professionals in any profession. They're very well trained in most situations. but they're still making these mistakes. And it's about using the processes we've outlined to support them. And we feel terrible. You know, I felt terrible, my colleagues felt terrible, and the family, in fact, we're almost grateful that we at least tried to fix it. But, you know, and we learned about that, and we did an after-action review, and we looked at the reasons why we'd made that mistake, and we've implemented that change into our MDT process, and since then, we've not made that mistake again. So, thank you very much. I'll take some questions if you have any. I don't know how long I've been going on for, but it seems like a long time. Are there any questions before we go? Let me look through here. Asim asked me about OVR to improve our practical level. How can we use OVR? Yeah, I've talked about that a bit, about understanding risk, stratifying risk, and therefore taking action to reduce the risk when you know what the kind of risk is. Some very good comments here. One hand can't clap about the teamwork. Mohammed's questions are always very insightful. Right. Okay. I'm going to sign off. Thank you very much, everybody. It looks like we've covered a lot. Please feel free to message me if you have any further questions, or inbox me on WhatsApp or on, I think it's called Messenger. If ever you're in Riyadh, please pass by and look me up. It'd be great to see you. And I extend my warmest greetings to all my friends, my family in Ipswich, who I miss very much. Hi Mo, hi Nadine, hi Jahan, my good colleague Dr. Hassan Gaddal, and his wife Pada, who are probably watching as well. Thank you very much. Assalamu alaikum.